Good afternoon, everyone. My name is Tim Michaelini. I'm the Regional Manager for Support Services here in the Northern Region in New Zealand, and I'd like to warmly welcome you to our weekly webinar series today. Today we are joined by Dr. Natalia Gavrilova, and she has an area of specialization in malignant and general hematology with interests in lymphoma, myeloma, and CLL. Her specialist training, she received a Bachelor of Medicine and Master's degree in Medicine in State Medical University, hopefully I pronounced that correctly, in the Russian Federation in 1997, and a Fellow of the Royal Australasian College of Physicians in 2013, and also a Fellow of the Royal College of Pathologists of Australasia in 2013 as well. She's a consultant hematologist at Waikato DHB, also a consultant hemopathologist at the Path Lab in Hamilton, and also principal investigator in myeloma and lymphoma clinical trials at Waikato DHB. She is also a hematology teaching coordinator at the Waikato DHB, and we are very, very privileged to have her along today to talk about aggressive B-cell lymphomas. If you have a question, there is a question and answer box at the bottom of your screen. If you can please put your questions through in that box, and Natalia will answer them as she sees fit or at the end of her presentation. Thank you, and we'll hand the time over to Natalia.
Thank you, Tim, and thank you very much for inviting me for these talks. It's a quite big privilege for me to talk to patients. I never had presentations like this before, and I hope this will be useful for you, and I would really encourage you to ask questions. I'm talking about aggressive B-cell lymphoma today, and Samar Issa, she presented a very beautiful talk about biology of lymphoma in general. I'm not going into this field, but I just briefly want to talk about just introduce the topic. We know that lymphoma is the cancer of lymphocytes, and there can be T lymphocytes and B lymphocytes. And lymphoma could be T-cell lymphoma and B-cell lymphoma. We know that B-cell lymphoma is the much more common compared to cell lymphoma, comprising up to 85% of all lymphomas. And also sometimes people ask me, what's the Hodgkin lymphoma and what's non-Hodgkin, what's the difference? And why the terminology is quite different. We know that Hodgkin lymphoma comprises 15% of all lymphomas, and it was described by Thomas Hodgkin as the first lymphoma. All other lymphomas after that were called non-Hodgkin. Actually, its explanation is very simple. We know that lymphomas can be quite aggressive disease, and I will talk more about this, and people need treatment urgently. But some lymphomas, like indolent lymphoma, can be diagnosed incidentally, and some people might never require treatment for these lymphomas. There are more than 80 subtypes of different lymphomas, and they're classified according to the clinical behavior, according to the biology, immunophenotype, genetic changes, and they're all described in this WHO book, which is a Bible for hematologists. When we do our training, we learn many subtypes of these different hematological malignancies. And this classification is continuously changing. The last was revised in 2016. The next one might be even more detailed. So the aggressive lymphomas, they're listed here. The diffuse large B-cell lymphoma can be divided into German-centered type or GCB lymphoma or ABC lymphoma, activated B-type lymphoma. And they're most common. In general, diffuse large B-cell lymphoma comprise up to 30% of all lymphomas. There are some other more rare subtypes like general CNS lymphoma or the lymphoma of brain, or Burkitt lymphoma, or primary mediastinal lymphoma. They're much more rare, and they're quite unique, and they often require different treatment. The most common sign of presentation is a painless lump. People can present to their GP doctors with lump in the neck that's relatively quickly growing. It could be lump in the groin or under the arm, but sometimes it can cause quite significant pain, especially if it's just growing in certain areas and pressing on nerves. Sometimes we see very large lumps like this in abdomen, and they can grow silently before they become very big. And people present with swollen abdomen and pain. And sometimes we see lymphoma can present in the chest as well, and it can cause pleural effusions. So you can see here is the CT scan of chest with a lump growing from the pleura and the fluids accumulating in the chest. But actually they can present in any other organs. We call them extranodal lymphoma. They can present in bones and stomach, in large bowel, in uterus. In addition to the localized symptoms, people might be quite unwell. It can cause impairment of kidney function. It can cause obstruction of kidneys. It can cause quite significant body pain, increase in calcium level. People come to hospital and they require urgent investigations and treatment. We also see other symptoms. You know about these symptoms, which are excessive night sweats, significant weight loss. We normally tell it's significant if people lose 10% of their body weight within 6 months. People often have loss of appetite, sometimes breathlessness, weakness. For aggressive B-cell lymphoma, we don't always see itchiness or skin rashes, but it can happen. But all of the symptoms I listed, they're not specific, and any other malignancy or sometimes infections can cause them, and the biopsy is crucial. The biopsy can be quite simple, like needle biopsy, but sometimes a surgical excisional biopsy might be required. There are pros and cons in different type of biopsy. For example, needle biopsy is very easy to do, and we're going to send people to pathologist who can do it relatively quickly or do it under ultrasound. And surgical biopsies would require admission under surgical ward and is reviewed by anesthetist, and it takes time. But the surgical biopsy will give us more tissue for diagnosis, and more precise diagnosis can be made. A needle biopsy is very rarely enough for lymphoma diagnosis. When people come to see us, we ask many questions. We really want to know a lot of things about patients. In addition to normal medical history, how things progress and how things develop in the time frame, we want to know about other medical conditions. We want to know if the person has diabetes, because some of the medications can make the diabetes very poorly controlled. We know if people have heart problems, because some of our medications can damage heart, and pre-existing heart problems makes the treatment more difficult. We also want to know if people have any pre-existing psychological conditions, because it can impair the ability to cope with the treatment and with the new diagnosis as well. We also want to know all the medications, because there could be some interactions with medications, or sometimes we have to stop some of the medications and restart later if need to be. We also want to know what's the level of functioning, especially the functioning before symptoms of lymphoma develop. For example, if a person comes with poor functioning, but it's all related to lymphoma, we presume that the treatment will be still deliverable, especially after prephase of prednisone, and people actually might get through the treatment quite well, and their functional status will improve as we treat lymphoma. We also ask about social support, because journey through lymphoma treatment is quite difficult, and it's difficult to do it alone. So family support, friends are very important. And of course, we do the physical examination. As you know, we would like to do a lot of tests, especially the blood test. like blood counts. We want to know the kidney and liver function test. We're always interested in serology and the special blood test to see if the person has HIV infection, because as you know that HIV can be associated with some types of lymphoma that is quite rare. We also want to know if the person had previous hepatitis B infection, because our treatment can make the infection visible when especially we start immunosuppressive therapy, and sometimes see reactivation of hepatitis B. LDH level is also important, and I'll talk more about this later. We would normally do electrocardiogram, and we would do heart function echocardiogram to assess the existing heart function, especially when we plan treatment with R-CHOP chemotherapy. Sometimes we also do bone marrow test, but it's not common anymore because we rely more on CT PET, which has very good ability to see if the disease can be present in the bones and the bone marrow. But sometimes still it's quite important. And we know that if diffuse large B-cell lymphoma, aggressive lymphoma present with the bone marrow involvement, it's usually associated with quite aggressive disease. Sometimes we also do lumbar puncture, especially when we can assume that the lymphoma can go and live around the brain, and we do it for diagnostic purposes. And very often we give a small amount of chemotherapy into intrathecal space. That's the space that contains fluids around the brain. And as you know that we do a lot of CT scans, CT PET and MRI scan. They're just some of the images so that you can see that X-ray showed a very large mass in mediastinum, but it's much more clearly visible when we do a CT scan. SMR is, I think Elaine can talk about the CT PET in details. In CT PET, we use slight radioactive sugar that has very good uptake to malignant cells, but also this will show up in any inflammation, and our brain likes sugar as well. And then a special camera is creating body image, and it's very accurate too. It does help us to stage the disease properly, to see if a small lymph node that otherwise not large contains lymphoma, and it also can show us if after treatment enlarged lymph nodes has dead tissue, fibrosis, or it still has a lymphoma. In this CT scan, you can see response after treatment, where all the lymph nodes became negative by CT PET. MRI scan, we don't see it often for standard lymphoma management. However, it's an essential tool when we talk about lymphoma present in the brain. We do it for diagnosis, we do it for assessment after treatment. And you can see the lymphoma is very visible on MRI scan. I can see there are some questions here. Yes, I can see this. One person is just asking about the symptoms and whether this affects prognosis, survivorship compared with someone without these symptoms. I think in the past, people thought that's probably important, that reflects the aggressive behavior of disease. However, it wasn't proven to be a very important independent prognostic factor. And we'll talk more about other prognostic factors that are much more important compared to just these symptoms. And we know that all of the prognostic factors, they need to be taken together, including the IPI score, including the histology, including cell of origin. I'll talk a little bit about histology. It does take time for the histology to be reported, and sometimes it can be quite frustrating for both patients and for us to wait for histology. But it does take time to do all these special investigations and proper diagnosis to be made. So this is the image of histology of diffuse large B-cell lymphoma. Here on picture B, you can see what's called cytology. Cytology, when you see all the cell details very clearly. Histology is really just slice of the tissue, and diffuse large B-cell lymphoma are normally characterized by quite large cells, and they have immature looking nucleoli, just dots here in the middle. And immunohistochemistry is a technique that uses antibody which are matching molecules that can identify and mark themselves to specific markers on the cells. And lymphoma depends very heavily on immunohistochemistry for correct diagnosis and treatment decision. And the combination of positive and negative markers allow to identify major subtypes of lymphoma. So you can see in this case, for example, the lymphoma is positive for CD20 antigen. You can see all these brown circles. These markers, they stain these large and diffuse large B-cell lymphoma cells with a marker. And we do know that CD20 is the receptor on the B cells where the actions happen when we use rituximab. This lymphoma is also positive for BCL2. And there's another marker which is quite important for us. It's called Ki67. It is the marker of cell proliferation. The higher the number, the more cells are in cell cycle, the more cells are growing continuously. Another important test is FISH, called fluorescent in situ hybridization. And this technique is used to search for presence or absence of specific genes or portions of genes. And FISH is very accurate. So you can see, for example, here, all the chromosomes can be clearly marked by FISH. And these probes, they can shine under fluorescent light. For patients with lymphoma, we use it quite commonly. And we really want to know if people have double hit lymphoma, that we talk about this later, or for example, Burkitt lymphoma. When we collect all this information, then we proceed to staging. The lymphoma staging is different compared to staging of colon cancer or breast cancer, for example. We call it limited stage when we talk about stage 1 and 2. In this case, the involved lymph nodes, they're on one side of the diaphragm. In advanced stage, there's stage 3 and stage 4, when the lymphoma can normally present on both sides of the diaphragm. There's also involvement of extranodal tissue, like stomach, for example, or involvement of other organs of bowel, for example. When the bone marrow is involved, we call it stage 4. And I'm going to talk about other very important prognostic information, IPI, which is International Prognostic Index for diffuse large B-cell lymphoma. You need to remember that was validated and defined on patients treated with R-CHOP chemotherapy. And quite a lot of information was pulled from many clinical trials to define the most important prognostic markers for diffuse large B-cell lymphoma. It helps doctors to predict overall survival and the risk of relapse, and also provide the basis for recommending either more aggressive or less aggressive treatment for patients. An IPI score is calculated for all patients by totaling the sum of the points scored for each of the risk factors listed below. So 1 point is assigned for age greater than 60, for raised LDH level, for reduced performance status more than 2, advanced stage disease 3 or 4, and also if there's extranodal involvement in tumor sites. There's also revised IPI criteria. The revision happened after R-CHOP became the standard of treatment rather than CHOP. And revised IPI criteria divide patients to very good when no risk factors are present, and the survival is really excellent with R-CHOP chemotherapy. The survival is still quite good if 1 to 2 risk factors are present, and there is an 80% chance of long-term progression-free survival. However, definitely more treatment and more investigations required to improve treatment results for patients with poor risk factors such as 3 to 5. As the survival long-term is only 50%. And you will hear in future talks about novel strategies and research that are happening in this field. And very often the research specifically concentrated for patients in poor prognosis. And 15 years ago, special studies were done to identify what's called signature of the genes. That was done by a very special tool called gene expression profile using fresh frozen tissue. And diffuse large B-cell lymphoma could be clearly divided into two subtypes, one called ABC, or activated B-cell lymphoma, and another is called GCB, germinal center lymphoma. And you can see the survival is quite varied. People try to reproduce this technique. This technique is not routinely available in normal laboratories. People try to use immunohistochemistry to define lymphoma that belongs to GCB versus ABC subtype. And quite few tools were created. However, none of it is perfect. And it's not in, there is quite some discrepancy between the two techniques people use. In our laboratory, we normally would use immunohistochemistry algorithm to define GCB versus non-GCB subtype of lymphoma. In the last probably 10 years, a lot of research has been happening to define subtype of diffuse large B-cell lymphoma further. For example, we know that some lymphomas can be what's called double expressor. Double expressor, when the lymphoma express of the 40% of their cells MYC gene and also BCL2 gene. I'll talk more about this. And the prognosis of that specific lymphoma is not very good. And we'll talk about double hit lymphoma as well. So scientists learned a long time ago about MYC. MYC is the pro-oncogene. It's the gene that really drives proliferation of the cells, pushes cells into a cell cycle, and also activates many other genes. When this MYC rearranged means it's translocated or put together with another gene that normally doesn't exist in normal cells. These genes become constantly activated, and that is one of the mechanisms of lymphoma development and progression. But in addition to this MYC translocated gene, there is another gene called BCL2 gene, which also comes together with another partner that pushes this gene into action. BCL2 gene is strong anti-apoptotic gene. So double hit lymphoma, in addition to being very aggressive and growing very fast, become quite resistant to treatment. These cells don't die easily with the treatment. The double hit lymphoma, they are relatively uncommon and account for 5 to 7% of all diffuse large B-cell lymphoma patients. In addition to the above mentioned risk factors, there is another IPI called CNS IPI. So this is really this was defined relatively recently, and it tells us the risk of progression or relapse in the nervous system. And In addition to using IPI risk score, if people have kidney or renal involvement, that makes the lymphoma quite aggressive and with a relatively high chance to proliferate in the brain. When we calculate this risk score and it's more than 4, we normally advise people to have additional treatment, very often with high-dose methotrexate, to protect them from lymphoma from the brain. Do you have any questions now? All right, and Tora now going to talk about treatment. Treatment with CHOP was introduced in 1976, and it became a backbone of treatment for aggressive lymphoma. When CHOP was introduced, quite a lot of work was done to improve on CHOP, because CHOP was the first curative treatment for aggressive lymphoma. And there was a lot of changes people tried to do, for example, including shortening the cycle length from 21 days to 14 days, or the more aggressive, the more cytotoxic agents were added, and sometimes even the transplantation, autologous stem cell transplantation was used in first remission for these people. But all of this treatment did not achieve good results, but induced more toxicity. But the real changes happened when rituximab was introduced. And rituximab has been in patent since 1998. So that was the first really example when CHOP can be improved so significantly by 20% across all group ages. You probably know about rituximab. Rituximab is a chimeric monoclonal antibody that targeted against PAM-B cell marker, which is CD20. And it is the first monoclonal antibody to be approved for therapeutical use. And when rituximab attaches to CD20 antigen, and the body natural defense system are recreated to attack and kill these cells. There are obviously a lot of questions people ask when we talk about rituximab. People do worry that the immune system will be destroyed by rituximab, because rituximab is affected not just lymphoma cells, but also normal B lymphocytes. And these B lymphocytes normally would only recover 6 months after the finished treatment with rituximab. However, very often we don't see significant problems with rituximab, and we don't really see significant increase in infection. And interestingly, the immunoglobulin level, that immunoglobulins they are made produced by the lymphocytes, they're not dropping significantly by rituximab treatment. That is the summary of clinical trials that compete CHOP or R-CHOP with other treatment. For example, you can see quite significant difference here when R-CHOP in the past 8 cycles of treatment was a standard of treatment was compared to CHOP, and the difference in overall survival was quite dramatic, 70% versus 57%. But when other more intensive chemotherapy was used, for example, when R-CHOP was 21 was compared to R-CHOP 14, there was no significant difference here. Another study showed that using only 6 cycles of R-CHOP compared to 8 cycles of R-CHOP also didn't cause significant difference. And R-CHOP for 6 cycles became the standard treatment for advanced stage diffuse large B-cell lymphoma. Another more aggressive treatment, such as ACVPP, was tried in Europe, and in some European countries, this treatment is used for very aggressive lymphoma in young people. However, in randomized clinical trials, it was very hard to show the difference. Obviously, the clinical trials don't really tell the whole story, because very often It takes time to enroll patients into clinical trial. It might require additional biopsy, it might require additional scanning, bone marrow test, and only people who can wait, who have relatively asymptomatic disease, who don't require immediate treatment, normally enrolled to clinical trial. For the people who might have poor prognosis might not get into the clinical trials. And the results of clinical trials, they're often better than life. I want to talk about side effects of R-CHOP chemotherapy. Some people experience it on themselves, and it's interesting to see there's a quite significant variation how people respond to treatment and whether people have side effects, and if the side effects are quite prominent or just very little. Obviously, it depends on age. Older people are, their tolerance for the treatment is low. However, it's not always the case. I have seen people struggling with prednisone, part of this R-CHOP chemotherapy. As you know, the prednisone, we use a very high dose of prednisone, 100 milligram for 5 days. It can cause significant agitation and anxiety and poor sleep. It also can disturb diabetes, or even can induce diabetes in some people. And sometimes people tell this was the most difficult part of chemotherapy, to have this prednisone and have an experience up and down of this treatment. The other chemotherapy using CHOP is vincristine, which is known to cause peripheral neuropathy or nerve damage and often constipation. And sometimes we have to reduce the dose of vincristine and sometimes completely omit the treatment, especially at the end of therapy. And I definitely have seen constipation that can be quite significant. And I really encourage my patients to use laxatives as early as possible, because this constipation can be long-lasting and not always relieved by natural remedies. Another medication is cyclophosphamide. It can cause nausea, it can cause vomiting and diarrhea. It can push women into early menopause, and very rarely it can cause lung toxicity. But the dose of cyclophosphamide we use within R-CHOP chemotherapy is relatively low compared to some other chemotherapy regimen. And doxorubicin is the red one. It might be a tricky one to use because it can cause cardiac toxicity, and it can also cause hair loss. The cardiac toxicity is not very common, but it's difficult to use this medication when people have poor cardiac function prior to doxorubicin. And some people probably have some genetic predisposition to cardiac toxicity to doxorubicin. And I have been using cardiac markers such as troponin I to see if some symptoms that people might experience, such as palpitations or shortness of breath, related to doxorubicin cardiac toxicity. I'm just looking for questions and answers. Yeah, it's a very interesting question. Are the side effects affected by the type of lymphoma, or is it possible to predict who is more likely to have worse side effects? Well, it's very interesting, and it's very broad, really. We know that when people come with aggressive lymphoma to the first treatment, the side effects are worse within first chemo round. You can imagine that you have a lot of lymphoma on board, and the first R-CHOP cycle really kills 90% of these lymphoma cells. So your body really needs to cope with this process. We often give additional fluids intravenously. We might use more prednisone, like a pre-phase steroids or steroids after. People tend to have more infections after first cycle of chemotherapy. And I do definitely see people coming back to hospital quite often after first round of chemo. And I suspect that the older you are, the more bulk of lymphoma you have, or especially if lymphoma is involving the stomach or your bowel, when it can cause some necrosis in bowel and stomach, and it can lead to infections. These people are more affected by lymphoma. But for younger people with relatively low disease burden, I wouldn't expect the first cycle will be more toxic. But I definitely have seen that the chemotherapy side effects accumulate in cycle 5 and 6. They might be especially tough for some people. As people experience more tiredness, people need to relax more. And the risk of infection might be higher for some people because some people become more neutropenic after chemotherapy as the bone marrow is getting more tired. We use a lot of supportive treatment around R-CHOP chemotherapy, and I really encourage people to have a diary and to write very carefully all the medications, all the dates, blood tests, the dates for appointments in clinic, the dates of chemotherapy, and also write the notes about the experience, about what was helpful during the cycle of chemotherapy. And when you go for cycle 2, you actually can look back and see what was the worst day of the chemo cycle that you need to relax more. Then it will help you to cope, and it also will help you to ask the right questions when you come to the next appointment to the clinic. I really just want that people would take their full control of the situation, and I also encourage people to take anti-nausea medications very regularly in the first 3 or 4 days, especially like domperidone, which doesn't cause significant side effects compared to ondansetron, for example, that can cause constipation or headaches. We use GCSF injections, which is granulocyte colony-stimulating factor, or very often we use long-acting GCSF injection on day 5 of chemotherapy, but it can be varied probably in different centers. So these injections are very helpful for older people, because I have seen that some people really never become neutropenic, and some older people will just flying through R-CHOP quite well without even single admission. So yes, it is quite variable. I also have seen that constipation at the beginning of treatment, because of steroids, because of vincristine, because of ondansetron, for example, can really make people quite sick, and it can cause hemorrhoids, and they can become infected, and then it could be like a cycle that drives the infection. You also need to remember it's not just the neutropenia, it's not just the low white cell count that makes people sick, it's the chemotherapy effect of the body, because chemotherapy is not specific. It works to all rapidly growing cells. It means that it works in the hair follicles, it works in the lining of your mouth, it works inside of your bowel, and that's when the gate is open for the bugs, and that's when people really become sick. So normally we do see infections happening around day 7-10 after R-CHOP chemotherapy. But R-CHOP chemotherapy is spaced, it's every 3-week treatment, and people often would have some time to recover well and be prepared for therapy. We also try to give treatment on time. That's very important. When we start reducing the dose of chemotherapy because people cannot tolerate this well, we start delaying treatment because of significant complications, we know that the results might not be as good as the standard R-CHOP chemotherapy delivered every 28 days. In here, there's another question. The loss of muscle tone from prednisone is what my partner is finding hard to deal with. He's keen to do exercise to counteract muscle loss. Do you recommend that? That's a wonderful question. I really encourage everyone to do that. There was a study done in Australia, and I think it was a person who was working in the gym, and he really just organized a campaign for people on chemotherapy to start doing regular exercises. Because being on prednisone makes you lose muscles very quickly, and losing muscle makes people tired very quickly as well. And sometimes people never can go back to normal themselves because of the loss of muscle. if you don't have a line, and do really encourage people to actually to do lightweight to preserve the muscle. And we know that doing significant exercises during your chemotherapy actually makes you recover faster, and the risk of complications is much less. It even probably improves overall survival as well. It's a wonderful question. I thank you for asking that. I encourage my people just to have a daily walk. I ask people not to sit in the bubble trying to protect themselves from an infection. It really doesn't help. Again, obviously, if people, if you have friends or relatives who are sick with flu infections, they should not come and see you. You need to be careful when you go outside. You need to wash your hands, and you need to watch your food as well. So all freshly made food at home, cooked food, is good for you. But it's good to go outside. There is no danger from the fresh air to your body, and you won't pick up these bugs. Again, the infections often come from within your body, from this broken mucosa lining. That's when the bacteria is coming to your blood or to the other sides of your body. Yes, so exercise is critical, and I think it might be even more critical when you finish all the chemotherapy to improve this fatigue and to improve this, chemotherapy brain syndrome. I had a patient a long time ago. She was doing rowing during her daily chemotherapy treatment. I didn't know about that. She had a big line, and actually she was just sailing through the treatment, and she told me about her own exercises just at the end of the treatment. I was surprised, but then I understood why she done so well. I didn't mention the problem with rituximab. Rituximab can be associated with infusion reactions. It can happen up to 15% of people during the first infusion. That's why nurses give it very, very slowly, over 6 to 8 hours. In our experience, more than 90% of people can get through this quite well. Sometimes we have to stop rituximab, sometimes we have to give additional hydrocortisone pre-medication, but majority of people will just get through that. And then from cycle 2, the infusion will be given over 2 to 3 hours. I do often give prednisone for 2 to 3 days before rituximab. In my experience, it does reduce the risk of reactions to rituximab. Very rarely we see true allergic reactions or anaphylactic reaction to rituximab. I had just one person who really tolerate rituximab in the last many years. All right. So I mentioned before that R-CHOP chemotherapy is a very good treatment for people with low or intermediate IPI score. So again, general center phenotype, low stage, low IPI makes R-CHOP as a good therapy. However, when we talk about older people, when we talk about ABC type of lymphoma, or double hit lymphoma, or double expressor lymphoma, a patient with high IPI, R-CHOP is not adequate. However, there is no really proven alternative to this treatment apart from special situations. A couple of years ago, there was very good news in American Society of Hematology presentation. They talk about a FLIER trial on the efficacy of 4 cycles of R-CHOP only versus 6 in young people with diffuse large B-cell lymphoma. These people were younger than 60 years old. They did not have bulky disease. They had early stage. And these people did as well with 4 cycles of chemotherapy only as people with 6 chemotherapy, probably even better. And the overall survival was just wonderful. You can see these numbers here. So 4 cycles of R-CHOP chemotherapy and 2 additional doses of rituximab became the standard of care for this group of patients. When we treat older people with localized disease, we tend to give radiotherapy at the end So very often people end up having limited cycles of chemotherapy, 3 to 4, and then radiation to the involved site, and they have still very good prognosis. Double hit lymphoma. So it was recognized a long time ago that double hit lymphoma is very aggressive. And people who were treated with R-CHOP didn't do well at all. And then people tried to intensify the treatment, and one of the regimens really stood out. I'm talking about the book. So there's a difference compared with of survival patients with diffuse large B-cell lymphoma compared to other types of diffuse large B-cell lymphoma. I'm talking about EPOCH-R chemotherapy. I started to use this treatment in 2013. I came as a new hematologist at that stage, and my first patient had double hit lymphoma. We didn't know what to do at that stage. We started to use very aggressive chemotherapy, and he experienced a lot of side effects. But even with that treatment, he did not achieve remission. And then I found this article about this regimen used for patients with Burkitt lymphoma. Again, there was no really randomized studies done about this treatment. I just thought it might be a good idea. Why not try that? So this treatment is quite different compared to R-CHOP, even it uses almost the same medications that we use in R-CHOP, apart from etoposide. But this treatment is given over 96 hours in infusion. So you can imagine there's a quite significant difference in the time when the lymphoma is exposed to chemotherapy. So R-CHOP often given, each drug is given over 15 to 30 minutes. And the concentration, the therapeutic concentration of chemotherapy drug in the blood lasts for 30 to 40 minutes. While the therapeutic concentration in this regimen would last for quite a number of hours. We also use rituximab, we use cyclophosphamide, we use prednisone, much higher dose compared to R-CHOP chemotherapy. And this treatment is considered to be more intensive compared to R-CHOP. However, not as intensive as some earlier type of chemotherapy we used for double hit lymphoma. So this patient, he survived and he achieved good response. He eventually got through bone marrow transplant, and I hope he's doing very well now. All right. So when we use the EPOCH-R chemotherapy for double hit lymphoma, the results are much more encouraging. It has been reported to produce overall survival in up to 75% of patients with this aggressive disease. In our department, we have done audit recently, and we look at all our patients who are treated with the EPOCH-R chemotherapy, and we have very similar results here as well. Yeah, thank you. There's another very interesting question. Do you think R-CHOP backbone will be around for years to come? Or I think a couple of years ago, I went to a quite interesting presentation. I think it was in Lugano, very big lymphoma meetings that was happening every 2 years. And that question specifically was trying to be answered by hematologists from the United Kingdom. And he put all clinical trials, really just, I'm talking about the clinical trials that comparing R-CHOP with R-CHOP plus extra medication, which is often targeted treatment. And majority of the trials, unfortunately, were negative. There are still some trials that probably we are waiting for the results. For example, addition of lenalidomide or addition of ibrutinib to R-CHOP backbone to improve results, or very specific subtype of lymphoma, for example, ABC type of lymphoma, that don't really respond as well. And again, there's no really positive results yet. For example, R-CHOP was compared directly head-to-head with the EPOCH-R chemotherapy, and people were very, very excited about that, and everybody was waiting for the result. So the result came him up a couple of years ago, and unfortunately the result was negative. But again, there's a problem with these clinical trials. When we talk about patients who go into clinical trials, they're often fitter people who don't have the aggressive disease and wait for all these investigations, and who otherwise would have relatively good prognosis. And they also would just put people together with different small subtypes of lymphoma, including double expressive, double hit, ABC and GCB, and they couldn't see the result. And they don't really power their trials enough to answer very specific questions like whether in randomized study the R will be much better to R-CHOP in that specific type of lymphoma. Again, we don't have the trial result. We don't have these trials answering these questions. I really hope that in future we'll have more clever and more targeted treatment. But again, it's very hard to beat R-CHOP chemotherapy. It's something magic about this combination. Nobody really knows why that specific combination and this specific dose really works very well. Again, I think the future is for really good, strong targeted therapy. But I suspect there will be another probably 10 years to really see quite significant differences in this front. We really want to give the best treatment and give the best shot for diffuse large B-cell lymphoma upfront. Because when the disease comes back, the situation is often quite difficult. If people are young and fit and a candidate for strong chemotherapy, people would normally go for salvage chemotherapy with a combination of quite high doses of chemotherapy drug. We call it RISE, we call it RGDP, we call them RDHEP, and some other. And then when people achieve good response after 3 cycles of chemotherapy, then we proceed to autologous stem cell transplantation with BIM conditioning. The BIM conditioning is really just the cocktail of high dose of chemotherapy that is given over 5 to 6 days, and then your collected stem cells are going back. The aim of the treatment is really to give high dose of chemotherapy to resistance of these lymphoma cells and support your bone marrow with stem cells. Because the BIM chemotherapy, if unsupported with stem cell transplant, can cause bone marrow aplasia, and people will be very vulnerable for infections, bleeding, and other problems. It's quite a big and growing field. You heard a presentation about CAR-T therapy, and you will hear about some novel regimens and novel medications that just come in the field. Very often they're concentrated on this group of people who relapse after initial treatment with R-CHOP or DEPOC therapy. Right. I want to talk about Burkitt lymphoma briefly. You can see there's not really much time left. The Burkitt lymphoma is the fastest growing cancer in human. It can be endemic, it can be sporadic, it can be related to HIV infection. In the developed society, we're talking about sporadic type of lymphoma, the Burkitt lymphoma. It comes more often in children and young people. However, it can happen in older people as well. The histology is quite interesting. The pathologists describe Starry's cry pattern, and often the Burkitt cell can express this little vacuolation in cytoplasm. And the Starry's cry referred to the stars, which are actually macrophages or the scavenger cells eating the debris of these Burkitt lymphoma cells. They just die spontaneously because there are too many of them and just growing too fast. And the hallmark of this Burkitt lymphoma is the translocation of this MYC. So MYC, when it's come together with another gene called immunoglobulin heavy gene, really become crazy, and that what really drives this very rapid cell proliferation. but the treatment for Burkitt lymphoma is quite successful. For younger people, we prefer to use high dose of heavy-duty chemotherapy that gives very good penetration to the brain and protects the brain from lymphoma growing there. But older people won't be able to tolerate the treatment, and the POC-R chemotherapy is becoming like a standard of care for this group of people. And actually, it can work very well. We had few patients with Burkitt lymphoma in our department. They were cured with the POC-R chemotherapy. A couple of words about CNS lymphoma. Sometimes it can be diagnosed quite late because people present with non-specific symptoms. It could be memory loss in older person. It could be maybe some headaches. Some people present with stroke-like symptoms, and the brain biopsy is required to make the diagnosis. When I started as a hematologist here, I didn't see many patients with CNS lymphoma because they were treated by medical oncologist in our hospital. And that was my biggest fear. If on call day, I would see patients with CNS lymphoma. And that's really because we didn't have a lot of knowledge 15 years ago. But we are seeing more and more clinical trials. And the result of these clinical trials are quite encouraging because CNS lymphoma is quite a treatable condition. In the past, people would have radiotherapy for this disease. It's very rarely used now. Instead, we tend to use quite heavy-duty chemotherapy with medications that can penetrate blood-brain barrier. And at the end, we often would give bone marrow transplant or stem cell transplant with very good results. You can see that survival after kind of 2 years could reach 85%. For older people, it's not possible, and however, we can still reach remission, and we possibly can maintain the remission with gentle oral chemotherapy drugs. So we have quite clear guidelines about this lymphoma, and I definitely know what to do if I call and somebody comes with this disease. Quite unique is primary mediastinal lymphoma. It often happens in younger women. It can present with kind of quite unusual symptoms. People might have cough, chest pain, purplish face, because there might be compression of the big veins in the chest and the blood doesn't flow back well. And people present often with localized mass in the chest. In the past, it was treated with R-CHOP chemotherapy and then radiation to the lump. However, you would imagine that for young women, it's probably not a good idea because the radiation can cause some damage to the breast, and people might be with breast cancer. And it also can damage the coronary arteries, and people might be at risk later for risking heart disease. However, treatment with the POC-R chemotherapy gives wonderful results, and this is standard treatment now for these women. All right, I think I finished, and I really would just ask if people have any questions.
We don't have any questions as yet, Natalia, and thank you so much for your presentation. I did have one question just for you. Obviously, a lot of people recover from diffuse large B-cell lymphoma and their treatment. And I asked this of Leanne when she had her presentation. But in the Waikato, what do you guys do for patients who recover from diffuse large B-cell lymphoma? As in, do you have a survivorship program in the Waikato? Because I know a lot of patients, they have their mentality to get through the treatment for those 6 cycles, and they're strong. You don't hear anything from them, but once they finish the treatment, about a few months down the track, they kind of feel the kind of coming down from that high, and they have a lot of psychological impacts from the treatment, which they didn't think they would have had when they were going through the treatment.
It asks here the restart is required, or sorry, it's not about Zoom. I agree with you. I think there is a quite different stages how people come to this diagnosis and treatment and what happens later. I think that initially people are shocked to learn about diagnosis, and then people learn it's a very treatable condition. People demobilize the resources as well as the family, and people just getting through that. And then later, especially young people, some people develop like post-traumatic stress disorder almost, when they realize that actually what happened to me. Some people start worry about multiple symptoms and experience that the similar symptoms like pain in the areas where the lymph node was excised, and nothing can stop this until sometimes the CT scan. Sometimes it's not clinically indicated because there is nothing to palpate, everything is okay. But sometimes it does help people to go into the new level when they really confirm that yes, I'm in remission, yes, I'm doing well. And I normally tell just that time will help you because this kind of post-traumatic stress disorder doesn't go away by itself. And sometimes I tell people just don't allow this to affect the rest of your life. Because again, in my career, I'm just feeling that the psychological well-being is as important as the physical well-being. The family is critical, and I'm always just asking to mobilize the family support. I'm asking this, husband and wife to help with this kind of diaries and to help people, to review the medications and be very heavily involved in all what is happening with the people. We don't have a standard survivorship program. We do monitor our patients up to 5 years in general. And I guess as a hematologist, we can deal with all these concerns. Often people put on weight after R-CHOP chemotherapy, and I suspect it's related to high dose of prednisone we use there. And also people are encouraged to eat more when they get through chemotherapy, and we probably kind of continue when we finish. And I do encourage people just to go to regular physical exercises and watch the diet after we finish chemotherapy. What else? Sometimes we do see kind of heart problems after chemotherapy, but I have seen it's getting better in the majority of people. So some medications can be helpful. Referral to a cardiologist can be helpful as well. Kind of this type of long-term problems. Neuropathy can be a problem. It can cause impotence in men. It can cause chronic constipation for some people. And sometimes we just make a referral to urologist. I definitely apparently there's a way to refer people to have some sexual therapists, for example, especially for young people. It can be a problem, and we tend not to ask these big questions. But sometimes people do come to us with this type of problems. Yeah, I would encourage people to come to hematologists, come to the nurses, CNS nurses, and we might really try to find a way how to help in this area as well. We have cancer psychologists who are really, really helpful, and they kind of normally see people. They give them kind of coping strategies how to get through the treatment. There are some counseling that can be helpful as well. I know in Rotorua area, they have a groups for children whose parents are getting through chemotherapy, and I heard from the parents and from children that was very, very helpful. Yeah, so I think the whole family really need to kind of rise to the help and beat this disease.
Awesome. All right. We have 3 questions here. If we just mindful of your time, if we answer these 3 questions and then we'll close it from there. Is that okay?
Yes. All right. The first question I can see: how common is progression from indolent to aggressive lymphoma? Does this affect treatment and prognosis? Yeah, so I didn't mention that I talk about primary diffuse large B-cell lymphoma, aggressive lymphoma, but the lymphoma can progress from follicular lymphoma, from CLL, I think it depends the progression. For example, if we do see follicular lymphoma at the diagnosis and the progression, regressive progression happen at the same time, the prognosis is probably better. We will treat it for aggressive lymphoma, and these people normally wouldn't require bone marrow transplant upfront. However, if people have follicular lymphoma for many years and transformation happen later, the prognosis is not as good and more aggressive treatment would be required. Fortunately, we don't see this often. I can't tell the exact numbers, but we're talking about single digits, maybe 20 to 25% chance of progression of follicular lymphoma to diffuse large B-cell lymphoma in general. The CLL can progress to what's called Richter transformation. It is very rare, and we often see quite later down track when CLL was treated in the past. People getting through the second and third line of treatment, CLL becomes more aggressive, and then Richter transformation can happen. And again, the prognosis is not as good in that situation. Any concern for secondary cancer for treatment? An older person. We know that the chemotherapy is not benign medication. In addition to the immediate side effects, it does damage the stem cells, and it can cause what's called secondary myelodysplastic syndrome or secondary acute myeloid leukemia. But we're talking about very small chance of this to happen, probably 1 to 2% only after CHOP chemotherapy. Obviously, if people have relapse disease, they need more chemotherapy, they need to have a bone marrow transplant with this BIM conditioning, the risk is getting higher, but we're probably talking about 10%. However, when we add radiotherapy to chemotherapy, the risk of secondary malignancy is definitely getting higher, but it's still in very low numbers in general. So we normally would tell, yes, it's there, but we actually have to beat the lymphoma first. We still have to do the maximum, the best treatment up front. The chance for secondary malignancy is very small. I'm post-treatment 1 year ago, still a bit concerned about return of lymphoma. I get followed up, but I'm checking my notes. What's the rule of thumbs of nodes if they're 2 centimeters or bigger? Thank you very much for this question. It is a very common question. So I know that almost all people check their lymph nodes, especially if they're palpable, especially when you felt and you know what it is. So for people who are young and who are slim, and especially for women who have long neck, it's actually normal to feel the lymph nodes, but they're normally small and they feel kind of quite different. They're normally smaller than 1 centimeter. They're mobile, they're not changing much. Sometimes much people have kind of throat infection, or, sore throat. The lymph nodes here might get tender, a bit sore, and that's quite normal as well. That's our immune system fighting with infection. The lymphoma lymph nodes, they're not painful normally, and they felt quite differently. They also felt quite differently from solid cancer. Solid cancer, they're quite hard lymph nodes, but the lymphoma nodes, they're relatively soft. If you're talking about diffuse large B-cell lymphoma, it's progressing relatively quickly. It's not sitting, in 0.7 millicentimeter in diameter for weeks and weeks and weeks. It does grow. We know that the risk of relapse of diffuse large B-cell lymphoma is highest in the first 2 years. After that, risk is getting smaller. But I think it's normal to worry about the lymph nodes, and it's very normal to check the lymph nodes, and everybody would do that. I, for example, had a melanoma excised from my arm, and for 2 years, I had this extreme pain in the arm. I thought, what is that? There's nothing to do with recurrence. It's some psychological kind of, worry, and again, that's normal. Again, for sometimes when there's a concern and you worry that yes, there might be something there, or even to relieve the psychological discomfort, I would do CT scan for people who worry, and it does help tremendously to people. But again, if you feel that the lymph nodes are small and they're less than 1 centimeter, they're not changing, they're not growing, it's unlikely to be lymphoma coming back.
Awesome. All right. Well, Natalia, I'd like to thank you so much for your presentation today.
I hope it was helpful. And
it was extremely helpful.
Yeah, I think the communication with your hematologist, I'll come preparing for a consultation. Write down the questions, know your IPI, know where you are. I think this will help you. Like, you know, when you're a young person, you obviously worry about your children, about your career, about what's happening in your life. It's a serious disease. But, you know, I'm telling people, that's where you are. You have 90% of chance to be cured. You just need to get through this treatment, you know, with this long-term outcome, without psychological kind of stress disorder. Just do the job and hopefully carry on with your life.
All right. Thank you so much, Natalia. And if there was an audience here, everyone would be clapping right now. So I'll just clap for you.
Thank you.
And we hope that you enjoy the rest of your day.
Thank you very much. Thanks, Tim. Thanks, Matt.
Thank you, everyone.
Bye-bye.